So we're going to be talking about diabetes mellitus. This presentation is brought to you by Lauren, Diana, Andrea, and Melissa. First, we're going to talk about the pathology of diabetes. So diabetes can be classified into two groups, type 1 and type 2. Type 1 diabetes is insulin dependent, and it is due to destruction of beta cells in the pancreas. This is usually a rapid onset, and it starts at a younger age. Type 1 diabetes always requires insulin replacement because of the beta cells. They are no longer functioning. Type 2 diabetes is not insulin dependent, usually occurs in older adults, and is caused by the pancreas under producing glucose. Type 2 diabetes is usually treated with diet and exercise, and insulin if alternate measures aren't effective.
So pathology of diabetes. Diabetes is characterized by complex disturbances in metabolism. Diabetes affects carbs, protein, and fat metabolism. Signs and symptoms of diabetes include hyperglycemia, which can be seen as a fasting blood sugar level greater than 126, and glycosuria, the presence of sugar in the urine. Those with diabetes are at an increased risk of these disorders: atherosclerosis, retinopathy, neuropathies, and nephropathy.
Diabetes can be diagnosed by monitoring fasting blood glucose levels, and sometimes glucose tolerance tests. Glycosylated hemoglobin, or HbA1c test, provides a 3-month average of glucose levels. This test does not require fasting before blood is drawn or the oral intake of glucose before testing. Anything that is above 6.5% is an early indicator of prediabetes. The goal for diabetic patients is to have an HbA1c level less than 7%. For culture considerations, Native Americans, Hispanic Americans, and Japanese Americans have a higher blood glucose level than Caucasians. African Americans, Native Americans, and Hispanic Americans are more likely to develop diabetes.
So this slide is just kind of a picture of comparing hypo versus hyperglycemia, and it just kind of gives you an overview of the signs and symptoms, the onset of it, and kind of the treatment or what they need for it.
Okay. Hypoglycemia. So hypoglycemia is characterized as a blood glucose concentration lower than 60 mg per dl. This can be caused by starvation or treatment of hyperglycemia with insulin or oral agents. Lower blood glucose levels have gone too far. Cells require glucose to survive, so the body reacts this way. Signs and symptoms of hypoglycemia are headache, blurred vision, weakness, muscle spasms, palpitations, cool and clammy skin. A way to remember hypoglycemia could be cold and clammy, need some candy. For hyperglycemia, the fasting blood glucose level is greater than 130. This is due to an increase of insulin in the blood. The signs and symptoms of hyperglycemia include fatigue, lethargy, irritation, glycosuria, polyphagia, polydipsia, and itchy skin. Signs of dangerous complications of hyperglycemia include fruity breath, dehydration, Kussmaul's respirations, and loss of orientation and a coma.
So going back to hypoglycemia, treatment for this would include, if the patient is alert and oriented, you're going to go ahead and give them a simple carb such as juice, hard candy, honey, sugar, or glucose that contains 15 grams of a carb, and followed by a complex carb such as a glass of milk, fruit, or bread. Then you want to recheck the blood glucose level after 15 minutes. Usually you're going to go ahead and repeat this 2 to 3 times, and after the third treatment you should anticipate starting an IV infusion of 50% dextrose if the treatment didn't help. If they are unconscious, then you usually just want to immediately go to IV 50% dextrose.
Hyperglycemia treatment. Hyperglycemia treatment should be treated immediately with insulin. If it's not treated right away, there could be serious consequences such as diabetic ketoacidosis, CNS changes, coma, or even death. Insulin is used to treat type 1 and type 2 diabetics that have no response to diet, exercise, or other agents. Insulin is a hormone produced by beta cells in the inlets of Langerhans in the pancreas. The action of insulin is they are released into circulation when the levels of glucose around these cells rise. They stimulate the synthesis of glycogen, the conversion of lipids into fat stored in the form of adipose tissue, and the synthesis of needed proteins from amino acids. Originally, insulin was prepared from pork and beef pancreas. Today, insulin is prepared by recombinant DNA technology and is human insulin produced by genetically altered bacteria.
So insulin adverse effects include weight gain, hypoglycemia, cough, irritation, ketoacidosis if severe, sweating, drowsiness, confusion, and again, cool and clammy skin.
Drug interactions with insulin. When given with any drugs, these decreases glucose levels, so beta blockers, MAOIs, salicylates, and they will mask the signs and symptoms of hypoglycemia.
Nursing considerations for insulin. You want to monitor for hypoglycemia at peak times. You want to make sure you store your insulin in a cool place and away from direct sunlight. Once you open your insulin, it can only be stored up for up to a month before you have to get rid of it. You want to monitor the patient's diet and make sure they are eating when they are taking their insulin. You want to help patients deal with lifestyle changes they will have to make, such as diet and exercise. You want to gently rotate the vial containing the insulin and avoid shaking it. You also want to monitor the urinalysis for glycosuria. And finally, you want to monitor the skin for any reactions, bruises, cuts, or infection. For insulins, our first group that we're going to talk about is rapid-acting insulin. So in this group, we have Novolog and Humalog. With Novolog, you want to administer it within 5 to 10 minutes of a meal. The onset is 10 to 20 minutes. Peak is 1 to 3 hours. Duration is 3 to 5 hours. And you want to give this subcutaneously. And the appearance should be clear. For Humalog, you want to administer it again within 5 to 10 minutes of a meal. The onset is less than 15 minutes. The peak is 30 to 90 minutes. The duration is 2 to 5 hours. The route is subcutaneous and the appearance should be clear.
Then we have the intermediate acting insulin. This is our NPH, our Novolin N. It's administered, it can be given with short-acting insulin only. Its onset is 1 to 1.5 hours, and its peak is 4 to 12 hours. Its duration is going to be 24 hours. Its route is going to be a sub-Q, so this one cannot be administered through IM. And this one has a unique characteristic that its appearance is cloudy, and that is a normal sign of the medication.
Next is your regular acting insulins. So these can be administered within 30 minutes of a meal. Onset is usually 30 to 60 minutes. Peak is 2 to 4 hours. Duration is 6 to 12. The route can be IV or sub-Q, and this is the only insulin that can be given IV. The appearance is clear.
Our final group of insulins is our long-acting insulin. This includes Levemir and Mellitus. For Levemir, you administer it once a day at bedtime. The onset is 1 to 2 hours. Peak is 3 to 6 hours. And the duration is roughly 6 to 24 hours. The route is sub-Q, and the appearance should be clear. For Mellitus, this is also administered once a day at bedtime. The onset is 60 to 70 minutes. There is no peak. The duration is 24 hours. The route is subcutaneous, and the appearance should also be clear.
So this is a good illustration of all, kind of like recapping of all the types of insulins we talked about. As you can see, each one's different. So depending on your short-acting or your long-acting, they all have different times of onset, different times of peak, and different times of duration. So it's important to know when the onset and peak of duration of these insulins are because for safe, effective treatment of diabetes and to avoid any side effects such as hyperglycemia or hypoglycemia.
So our last slide is just showing you how to administer insulin. So you have your different areas. So the upper outer arms is an area, your abdomen, your buttocks and your upper outer thighs. Typically, the fastest absorption route is your abdomen, so you usually go for that. And it's important to teach your patients about rotating the site. And routes, again, can be subcutaneous, intravenous for only regular insulin, and then it can also be inhalation. However, subcutaneous is usually the most regularly used route.